Hey, everybody. It's been said that the only constant in life is change, and medicine and this podcast, no exception. So, since this was recorded in 2022, there's been some changes to the EMS protocol that aren't reflected in this video. The first of which is TXA. Although all the administration and all the other philosophy about TXA discussed in this video is absolutely correct, the dose is now changed from 1 gram to 2 grams, given in exactly the same manner described in this program. The second is push dose epi. Although in the program we refer to 10 mics every 2 to 5 minutes, that is now changed in 2 ways. The first is the timing is completely abolished. As soon as you know you need the drug, you can go ahead and give it to stabilize your patient. Furthermore, you may give up to 50 mics per dose as your patient requires to stabilize their blood pressure or heart rate. Hope you enjoy this operational pharmacology podcast. Welcome back, everybody. This is the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim, and today we have our regulars with us. Directly across from me, we have firefighter paramedic Ray Pace. We've got firefighter paramedic Caleb Ferroni, and our guest today, Dr. Don Spanner.
Hello.
Hey, thanks for joining us, man. This is we got a bunch of stuff to talk about. There's specifically there's some things that you've been very passionate and had to get all kinds of information out to the troops here as of late, specifically about ketamine, and we could really think of no better forum than to get you on here, talk about this stuff beyond just the 200 300 word emails that you can send out that
right.
95% of the world ignores because
thanks.
We're all tired of emails. Nobody reads the emails.
All right, write the junk mail.
The fact that we jam it right down their throat in Health EMS every time they log in, it's reminding you, but still there's way more backstory than we can accomplish in a couple hundred words, and really that's kind of the first big bucket of things we need to talk about today is kind of like all things ketamine. We went from our last podcast with all things CPAP, and we really want to talk about all things ketamine.
Okay.
And really, I guess the first thing that I'd like to tackle on our list here is why are we so upset about this? We have other hypnotic sedatives, we have other analgesics, and we're not quite as wound up about times where maybe it was used inappropriately or they were marginal cases, or why don't we pay that much attention to everything else? Why is it this that we're so hyper-focused on right now?
So ketamine's gotten some bad press.
Yeah.
And I will tell you that you deal with medications as a physician according to your own experiences, certainly by your training. So I can tell you my first case of ketamine was a gentleman who ended up having West Nile virus encephalitis, and he was pretty out of control.
Was this in the ED?
Yes, this was in the emergency department, and I ended up giving him a sedation dose of ketamine. I was able to do a lumbar puncture and get his spinal fluid. And of course, it lasts 15 minutes. There's no reversing ketamine, but when they come out of it, they can have this very unusual event called an emergence phenomenon. This was, of course, 30 years ago. And he emerged. He emerged violently and started smashing his head against the wall and became a bloody mess. Not really what you consider ideal after a lumbar puncture. And I had to paralyze him and sedate him and intubate him. He would have probably ended up intubated because of how profound his encephalitis was, and thank God he actually recovered completely. But that scared me. I mean, to the point where I was like, yeah, I don't think I'm going to use ketamine anymore.
Right, yeah. I mean, we've worked together a long time. I've actually never heard this story. You said it was 30 years ago.
It was a very profound...
Early in your career, yeah.
Yeah, it was a very profound story. And you don't like to talk about things like that, but it is something it petrified me from using ketamine for years. And then after 9/11, I was downrange a number of times, and ketamine became the drug of choice for sedation.
Sure.
And the reason behind that is that it decreases post-traumatic stress in our soldiers by at least 50% because of its profound amnestic event. And so I suddenly realized, Don, you might have been avoiding this for 10 years, but you better get on the stick.
Based on one case. Yeah.
Right. You can't change your career over one case, but it certainly gives you pause.
Of course.
And so I started utilizing ketamine pretty significantly downrange, and I started bringing that home with me and saying, it's not the devil's drug. I also understand that any drug can be dangerous,
yeah.
but ketamine, for some reason, likes to make the headlines.
It does.
So in Colorado, there was an individual whose significant other was telling the providers that her significant other goes very aggressive when he's hypoglycemic and he's a diabetic.
Sure.
She warned them. She warned the police. The police were in a violent struggle. The police then asked to use that ketamine. Get that ketamine. We can't control this guy. And certainly he was out of control. But the providers, I'm not saying that it was inappropriate because they couldn't control the situation. He was aggressive with the police. He was aggressive and could have hurt himself or others.
Right.
And I'm not saying that that was not the choice, but certainly if you have an identifiable cause, you need to treat the cause, and the whole situation would go better. So they did sedate him, but nobody checked his glucose.
But then they never moved on.
They never moved on.
Yeah.
This actually went to an emergency department that was approximately 25 to 30 minutes away.
I wasn't aware of that transport time.
Is a long transport time to be hypoglycemic, and we don't know how long he was hypoglycemic before that. The emergency department in Columbine, Colorado, is where this happened, actually recognized hypoglycemia and treated it and normalized the glucose. Unfortunately for this young man, he was left hypoglycemic for such an intractable period of time that he was taken off life support 3 days later, and he was dead. Absolutely unconscionable. So we're pretty aggressive about how we review every ketamine use, whether it's for pain management, whether it's for intubation assistance or RSI, or whether it's for psychiatric violence. And for that reason, we pretty much cover our bases. That doesn't mean we don't have providers that need re-education, but we are all over it.
I guess the other piece of that, kind of amplifying that story, is that then the lawmakers bid on that, and in several states there's basically I don't know how to better term it other than anti-ketamine legislature, yes. Right? Somehow dictating to medical professionals what agents we are going to have available to us, and
that's exactly what happened.
That's exactly what happened, right?
And happened in Ohio. I mean, they're looking very aggressively at Ohio, so we got our ducks in the row. You guys got the ducks in the row.
Correct. We can't be the trigger for that to
No.
to come down in Ohio.
Exactly.
Yeah, that's. Yeah, we simply can't have that. So, I guess that also kind of flows into what do we do on the UH side? What is the process? How do you know? How do you know about what cases happen here in UH, and which of those cases get reviewed?
So, John Cameron sends us weekly, or at least every other week,
right?
Cases of all the uses of ketamine. And they are reviewed by all of our medical directors. We have a really nice team approach. I mean,
actually,
one person could not do this.
I want them to know that, right? Is this isn't just their medical director
Right.
hyper focused on something. The entirety of the team
Right.
is out there.
Which isn't just 2 or 3 doctors.
It's not.
It's a team.
It's at least 10.
Yeah.
To say, I think there's 15 on that mailing list,
Right.
and then there's probably another 6, 8 paramedics and
Coordinators.
And if you guys notice,
coordinators roles, yeah.
too.
the responses come from everyone. I mean, we all kind of look them all over, which makes it really nice because some of us maybe are a little hyper-vigilant. Others, are like, okay, look, they did the right thing. Here's a subtle way that we might improve. But I will tell you this, with that many physician EMS medical directors watching everything, it's very hard to actually see issues. I mean, we have appropriate use of ketamine for an intubation that went over our limit, and it was still a very appropriate use of ketamine, and it was using a standard calculation that would have been appropriate.
Sure.
But we do have a max of 200 milligrams. It's almost a shame that we had to say to the provider, hey, you went over the limit, because they did everything perfect. The monitoring, the capnography, the pulse ox, everything was followed exactly appropriately. And it was a larger person, so there was certainly no harm. But that still comes to our evaluation, and we say, look, great job,
But
don't go over 200.
But keep in mind that it
IV,
is,
that is.
yeah,
keep in mind. So, I mean, that really then, I guess, brings up the next points of, we actually have several things in protocol we use this for. This isn't, now you were talking about an airway case
Yes.
there. The previous case you mentioned, the Colorado case, that was clearly a violence case.
Yes.
But there's a third indication in protocol, right? And that's
I don't think it gets used nearly enough.
enough for pain.
I use it a lot, especially anyone who has addiction issues and will come out and be honest enough to say, look, I'm working a program.
I'm working a program. Yep.
Don't mess up my program,
We've had
because
exactly
if you
that.
give someone like a narcotic who's trying desperately not to abuse narcotics, how does that help the patient? When you have an alternative, we have the Toradol, we have the ketamine. There's some alternatives for folks who are working programs, and we should be assisting them.
I agree. We had a patient fall into a pool with no water into it. Was
it's
injured.
not a pool.
So, well, it's a pool without
There's a
water.
big hole in the ground.
That's a hole.
It was a hole of concrete.
Shallow end or deep end?
Deep end.
Even worse.
But yeah, and that was the first words out of that person's mouth was like, I don't want any pain medicine. And the individual screaming in pain. You knew they were hurt.
Absolutely.
And we actually offered the 2 non-narcotic options, and I respected him. He didn't want anything, just because he's like, I just don't want anything. I really don't even want an IV, because it's a trigger, and we want to work
Right.
with those people. We want to build on that. We don't want to take
Absolutely.
anything away from all their hard work, years of hard work. We want to encourage them to continue on the right path. So I agree wholeheartedly with that. And it's
One
good
of-
for providers to know those other options are out there too. We didn't really talk about that much. Maybe in some of the protocol updates we did. I think
Right.
one of the protocol updates we talked about non-narcotic options for those recovering addicts.
Another example is sickle cell patients who frequently don't have any relief with narcotics because they're almost immune to narcotics. If you're all wondering why we're smirking, my dog just walked into the room. Sorry. He's a really good dog. So anyway, our ketamine for sickle cell patients, I have personally seen give relief when they've not gotten relief from mega doses of Dilaudid and fentanyl and such. And the relief that they have on their faces, they're like, oh my God, something that actually works. Because sickle cell pain is profound pain. And sometimes we have to come up with some alternatives. So I don't think the ketamine's being used as much as it should be for pain management.
But I think, to your point, it's going back to people afraid to use it because of all the oversight that's in it.
Yes.
And if you're doing it correctly, I mean, why are we afraid? And I think today will help. You're going to show how to mix it.
Yeah,
Push
yeah.
one, pull
Yeah,
one
no.
is just as easy as it gets.
Oh, actually, I thought you were mixing it.
Oh, I'll mix it. It doesn't matter. It is a very attractive drug to EMS, though, because it's used for so many different things.
Yes.
And used so well for so many different things.
Yes.
And it has almost the most amount of routes that you can give it. IV, IO, IM, IN.
IN, yeah.
It's very attractive. And it's been around for ages. 1962, I think, is when it was introduced. And it's been used. So
one of my favorite talking points, just being a sarcastic ass, about ketamine is that it's derived from PCP. I mean, this is
Nobody wants to
essentially-
talk about that.
We're not supposed to talk about that, but
It is.
It's
dust.
I think it's important to know, because when you give that, you see basically the opposite effects of all of our other analgesics and all of our other sedatives, right? So normally these patients become tranquil, they become sedate. And although they are becoming sedate and they're becoming tranquil, their vital signs when you give them ketamine will often trend up, right? We'll see blood
Yes.
pressure increases, we'll see heart rate
Which is
increases.
another reason it's ideal for our hemorrhagic shock
Sure, like a
patients
shock
with
trauma
pain, right.
patient, it's a great great use. You got somebody with a soft blood pressure, right?
Why give them a narcotic?
Yeah, right. Yeah. Maybe they're living on that sympathetic drive right now, right? And that's keeping their blood pressure at 84, right? And but they're still, your case, or our case was a femur fracture. Guy had fallen on a motorcycle and a femur fracture. Same thing. Was working a narcotic program. Didn't want anything, but he accepted in that particular case, he accepted the ketamine, and they gave him, and he had a soft blood pressure, and that was a very long transport time, and we watched the vital sign trends up.
And it's also a bronchodilator too. I mean, it is. There's so many.
Although they can get a little hypersecretion, so you just kind of watch for that. But it is a bronchodilator, kind of a last-ditch effort, believe it or not, for end-stage asthma. Just when you think you got to intubate them, that's a great drug to make an effort with.
I believe some of our critical care colleagues are mandated the use of ketamine for crashing asthmatics just for that reason. He said a trigger word. You said you said two of the non-narcotics, and of course the non-narcotic analgesics. Yes. Of course, we're talking about ketamine, and the other one is my least favorite drug is ketorolac. And I want to just make sure that we are not talking about equal levels of pain control here, and we're talking about different classes and calibers of drug.
Although Toradol, depending on the pain, if you're talking about renal colic, which can be pretty severe, because of its anti-inflammatory effects, does a pretty phenomenal job for renal colic. So you got somebody with sling pain, that you're not worried about a dissection on the left side, but somebody who's actually, a classic story of a kidney stone. Boy, the Toradol is the
and it works quick
drug.
too. From what I've seen,
Yeah, but that's it. It's inflammatory pain, right? It is not a non-narcotic replacement for fentanyl, for Dilaudid, and sadly, we've seen cases where somebody has go back to a femur fracture and they're giving them Toradol because they don't want to give them narcotics. Those aren't the same thing by a lot.
No, and that person's going to need surgery, and you do want to avoid NSAIDs.
Yeah, correct.
Prior to surgery.
Now we have bleeding concerns with the Toradol.
So I jotted down a couple things. One thing I wanted to bring up was that Indiana Department of Homeland Security ran a study through December 16th, 2016 through April 8th, 2021. And their conclusion with the use of ketamine was that out of hospital setting, it was that revealed that more than 9,000 patients received ketamine over nearly a 5-year period. And basically what they saw was that overall ketamine provided very safe drug to the vast majority of patients it was administered, and there was very few documented complications. So there is room for improvement, and I think that two of those rooms that they've mentioned here, we've already worked on: CO2 monitoring, cardiac monitoring.
Yes.
And I think that was pretty cool. But other than that, the study showed that it was relatively safe in that amount of patients. It was well received.
Even though we've identified some errors with ketamine, I don't think we've had any sentinel events at all because of how much training goes into it, how much oversight goes into it. And I don't know where we stand at university as far as size of EMS in Ohio. Any idea with all of our departments? We're close to 250 departments. I would imagine that we're close to 20% of EMS in the state of Ohio.
It's got to be.
It's got to be close to that. So our oversight is in the thousands. And although we don't see thousands of doses, we probably see 8 to 10 every couple of weeks. And we have not had a sentinel event either. I think it's an incredibly safe drug, like any drug, used appropriately, right dose, right route, right time, right patient.
I agree.
Right indication.
Right indication.
And I think the education is why. We're trying to prevent that sentinel event on the front end. We talk about it a lot. It makes providers, it has that bad stigma. We talked about it. We're trying to break that with good education, good indications, when to use it, the appropriate way to do it. That's why we're talking about it again. And the medical director engagement, I think, helps with that as well. So if somebody has a question, and our medical directors are all out and they're doing CE, they can say, "Hey, Dr. Spanner, I have a question."
There's
that comfortability level and approachability level, I think, that always prevents that with that education. That's my opinion on that. I think that's what really helps our process
Well, I think we kind of
it's a
covered
huge
that
team.
last episode too with Dr. Hill, where it was like we need to
Yeah.
break that comfort level where when can I come to you and say, hey, I have a real question about this. Let's talk about it honestly and help me figure this out. And
I can tell you that from the medical directors, my gosh, Tony Dare, Andy Garlisi, Jeff Luke, Frank Ford. I mean, the list goes on and on and on. Gary, my goodness, John Hill. I mean, name one of those people. I mean, and I know there's many more. Jay Carter out of Lake. I mean, we could go on and on and on. Glagola from Southwest.
Yeah.
I mean, we don't have an unapproachable person. And everybody should be incredible, because I know that some medical directors, don't want their phone numbers out. And that's not how any of our folks are. We're really approachable. So I hope that everybody listening to the podcast understands. You got a significant question, just call us.
no, I can vouch for that personally because Garlisi has called me at home before about something and said, hey, let's talk about this because you put a quote on your chart that said, can we talk about this?
Right.
So let's talk about it. And
Exactly.
It's been nothing but good experiences.
And that's what makes better providers.
It is.
That is what the takeaway point. You'll never forget that lesson learned too, where we bring in that patient in the ER and we have that question. That takeaway point when you leave that day is going to stick with you for the rest of your career. You pass on to more people, and the education it continues. And I think it's excellent.
There was a hard line for me to break in my mind. It took a long time, and really is, when I started working with you now 20 years ago. Prior to that, all the previous services I had worked for, I had no idea who the medical director was. Never met them, never interfaced with them at all. Saw their name on a document here and there. That was it. And I think there's this stigma of like, I don't want to get in trouble, right? And it took me a while to understand that, hey, you've screwed things up. You've made errors. You've gotten past those. Somebody was direct and
It's a
forthcoming.
newsflash. We're all human.
Yeah,
Yes.
right. But there's this persona, especially being new or being young, and the world needs to know that.
Although my Vulcan mother might disagree. No.
And when we screw things up, I mean, you've gone to guns on me for stuff that I've messed
Yes.
up, right? I mean, there was a intubation call early in my career. He was very direct, and you know what? I'm a better provider today because of it, right? It was like this is what you did wrong. This is what why this is how this should have gone. He let me air my side of it. This is what I was thinking, or really what I was not thinking, right? Here we are today, and there'll be more, right? But yeah, you should absolutely be able to approach your matter and use your EMS coordinators to start that conversation if you can't start it on your own, right? Like, hey, I need to talk with the doc or whomever, and
Right.
The EMS coordinator can facilitate that conversation if you're unable or unwilling, or so.
Yeah, we're very fortunate to have what we have. I just got back from a trip. Scott and I were talking earlier,
Yeah.
where the doctor that I had met was working in a very remote, limited access building where he was also the EMT on the ambulance.
Wow.
So it's amazing to see apples and oranges and realize that let's use what we have to our full benefit, and because they would pray for it. It's
Yeah. So anyway, back to things, all things ketamine.
Yeah.
Right?
Yeah. Doses.
Doses. So let's talk about the pain control doses.
Okay.
Actually, why don't we do this backwards, because we have to make the pain control dose.
Okay.
We don't carry the pain control dose.
Right.
So let's talk about the other two doses and indications and their doses,
Okay.
and then we'll come back around to
Okay.
slightly harder to do, but it's actually.
Do we have it here?
We do. We have ketamine, and we're going to break some down here in just a second. That's labetalol. Let's see. There's some ketamine right there. So the
500 milligram and 5
in
cc.
Yeah, 505. So
That's easy math even for someone who graduated Mayfield High School.
So
That would be me.
so for airway, I think there is in that patent column, patent airway column, if you need chemical assistance in taking their
Yes.
airway. I guess let's start with who do we need chemical assistance? If this patient's already obtunded, do they need ketamine? Because somebody
if they
can
have
literally read that
If
column.
they have a gag reflex, sure. If they have need for sedation, frequently they may need paralysis. And when they do head-to-head studies on chemical-assisted intubation versus rapid sequence intubation, at least in the emergency departments, the rapid sequence intubation wins every time. I mean, by far. When you're in the emergency pre-hospital environment, there are squads that have chemical assist, and there's squads that have RSI. And the chemical-assisted intubations are not as successful as RSI, but they're quite helpful. And our two drugs that we have are either a benzodiazepine for chemical assist. You're not going to get this kind of response fast enough with Ativan, but certainly with Versed you will. Sure. But Versed comes with untoward effects of hypotension and respiratory depression, which is really problematic in a head-injured patient. For example, you never want them to be hypoxic, less than 93% for more than a minute, and you don't want them to be hypotensive, less than 90 for more than 2 minutes. Unfortunately, a drug like Versed can cause both.
Help that along.
Whereas ketamine is not going to do that and may raise the blood pressure.
Actually support, yeah.
And certainly bronchodilate and give you the advantage of hopefully not getting hypoxic. So it is a phenomenal drug for chemical-assisted intubation. The dose is very straightforward, 1 to 2 milligrams per kilogram with at least 100 milligrams, because we don't want to be in that zone where they may be acting bizarre between 30 and 100 milligrams. Some people refer to it as the K-hole. That never really stuck with me. Just sounds weird.
So if I do that and I use that, do I still need to just go ahead and truck around with my succinylcholine or etomidate, or am I just good there?
Okay, so really good question. The ketamine for sedation, for chemical assisted, is going to last about 15 minutes. The advantage of ketamine is you can then give half the original dose and get them back over that threshold when they start coming around. Or you can do what a lot of people recommend, and that is use your Ativan if you're carrying Ativan, because you're not going to get that hypotensive effect that you'll get with the Versed. Or use small doses of Versed. 2.5 milligrams of Versed, you are never going to see that hypotensive event. You're never going to see that respiratory depression with a 2.5 milligram adult dose of Versed. And that'll buy you 20 more minutes of sedation. So that's just another option. So you can either give more ketamine or add a benzodiazepine. For me, I think adding the benzodiazepine avoids the emergence that some people get with ketamine. So if I'm giving them the 1 to 2 milligrams per kilogram, at least 100 milligrams IV, no more than 200 milligrams IV. So basically, you have your 500 milligrams and 5 cc's. You're basically going to give them 1 to 2 cc's. You don't have to dilute anything. You just drop 1 to 2 cc's. You inject the appropriate amount. The patient should be very sedated, or what we call disassociated, within 1 to 2 minutes. You then intubate the patient, and once you get everything set up, your pulse ox is on, your capnography is, side port is on, you're managing a head-injured patient, keeping the capnography at 35 because that's what you're looking for, making sure your pulse ox stays above 93, monitoring the blood pressure, and going, obviously, to a trauma center if you've got that kind of a significant head injury. The next move is sedate that patient. 2.5 milligrams of Versed if you have it, 1 to 2 milligrams of Ativan if you have it, is a nice, gentle way to keep that patient sedate and avoid any emergence.
But I don't necessarily have to jump to a paralytic.
No. The paralytic's only use in the field for squads that have rapid sequence intubation is placement of the tube so that the cords are paralyzed and you're controlling the situation.
And I know a few times that I've used ketamine for intubation, I haven't needed a paralytic. The ketamine itself.
Do you carry a paralytic on your squad?
We do not yet, but I wouldn't have needed it. It worked.
Okay, the reason I'm saying that is I'd like to maybe be more definitive on that. If I have ketamine and a paralytic, I don't want to, because every time you try intubation, you're increasing the risk to that patient. Because even during sedation or disassociation, there's going to be a drop in the pulse ox. That's why you have to have your pulse ox hyperoxygenated before you make your attempt. Whether you're using it with a 15-liter nasal cannula transiently for the intubation, or you're bagging that patient's pulse ox up. Once you go for the intubation, that brief period of time is going to drop the pulse ox, and then it's going to take more than a minute to get that above where you need to be. So, to be very specific, if you have RSI capabilities and you've been trained appropriately in it and you're getting checked quarterly, I don't want to get into the whole thing, but if that's how it works, do the RSI. You're going to have a more successful attempt, and I don't want you to get in the habit of thinking, you know what, I don't want to paralyze them, I'm just going to sedate them or disassociate them, and I'll probably get it. If you are trained as an RSI provider, you need to do the RSI.
And the flip side of that is, of course, if you're not,
don't.
Then clearly you're not permitted.
Right. Well, you shouldn't even be carrying.
You shouldn't have the agent to begin with. You're certainly not permitted. But there might be a department where some of the personnel are trained, some of the personnel are not trained.
Yes, but you have to have two RSI trained
Correct.
to do the procedure.
Correct.
You can't be doing it with just one RSI provider.
Hence, they would only be using a large dissociative dose of ketamine.
Correct.
Correct.
And the cool thing about ketamine at this dose is
Yes.
we're really got like 4 different effects simultaneously. We've got that dissociation.
That's a really good point.
Yeah. They're being amnesthetized. They're not going to remember this, right? Of course,
Analgesics.
they're going to be analgesied and they're going to be sedate, right? Now,
That's the beautiful part of ketamine. That, by the way, you don't get with the benzos.
That was my point. So it's listed on the protocol as either or. I want to make sure that the message is if you have either or, it's kind of the backup. The benzo only is a kind of a backup plan because you're not analgesing the patient. Yeah, they're going to be amnesthetized. Yes, they're going to be sedate. However, they can still feel pain. So a benzodiazepine alone, all right, is not as
Which is the other point I wanted to bring up, that if we are following RSI, unfortunately we're RSI trained, we just don't have our medications yet. If we follow RSI and we give ketamine and I give rocuronium, I better let you know on the receiving end that I've done that, because the rock's going to last a lot longer than the ketamine.
No, about the same.
Yeah?
So rocuronium lasts about 20 minutes. It's a dissociative. So, the rocuronium is a non-depolarizer. The ketamine is a dissociative. The dissociative effect for ketamine is about 20 minutes. The non-depolarizing paralytic effect of the rocuronium is about 20 minutes.
And succinylcholine?
Well, succinylcholine's very short-acting. So the rocuronium, because that's what I was thinking we were talking about, is rocuronium. Rocuronium is what's called a medium paralytic, and that's 20 minutes. The other non-dissociatives, like vecuronium, for example, Pavulon, those can last 40 to 60 minutes. So the reason, because the state of Ohio says you cannot use a long-acting paralytic in the pre-hospital venue, the reason we are able to start moving towards rocuronium is because it's an intermediate at 20 minutes of paralysis. Succinylcholine is a very effective paralytic, but it's a depolarizing paralytic. And many of our squads are carrying it now as we're getting ready to switch over to rocuronium. But the succinylcholine causes all the striated or skeletal muscle cells to fire until complete exhaustion. And then those muscle cells are exhausted for about 4 minutes, but it could be as long as 12 minutes. Most of the time you're talking about a 4-minute paralysis. That being said, it's one and done. It's not like if you give rocuronium and you've paralyzed the patient and you then sedate the patient with your ketamine. Actually, can I say that the other way
say
around?
that backwards.
You
yeah.
definitely want that
snooze him
patient
first.
You want that patient disassociated and sedated
Then paralyzed.
first,
Yes.
right? Nobody wants to remember that they were paralyzed without any sedation.
Very
that
much
would be
so.
terrible.
Very much not.
So everybody knows what I mean on that. But that being said,
There's a couple cutouts here. Don't worry.
oh, thank God.
I'm just trying to lead you to something. Sorry.
Is it the succinylcholine? You get one shot at it. If you need to add paralysis for an extended drive, or somebody who's fighting the vent, and you need to sedate and paralyze, you can repeat that rocuronium at half the initial dose. You can't do that with sucks. It's a venom, right? It's a neurotoxic snake venom. Who wants to be bit by a neurotoxic snake twice? So, did that answer your question?
I think so.
He doesn't even remember what the question
I
was
don't
at this
remember what the
point.
question was.
Sorry.
Just trying to lead you somewhere that I forgot about. And then,
I think
we should
Dr.
mix it.